I'd like to thank Julio and the organisers for giving me the opportunity to present an update on our HPTN 071 pop art trial, and I'm presenting on behalf of an enormous study team. I'd like to acknowledge them all first, actually. The pop art study is sponsored by the US National Institute of Allergy and Infectious Diseases and is funded through several US government agencies, including PEPFAR, NIH, NIMH, NIAID, and the Bill and Melinda Gates Foundation through 3IE. This trial is part of the HPTN network. We've been given a number, 071, but we've also been allowed to have a name as well, pop art. This is derived from an algorithm on the population effects of universal testing with immediate antiretroviral therapy to reduce HIV transmission. So pop art represents a large, unique collaboration between multiple disciplinary researchers, including institutions from the US, UK, Zambia, and South Africa. In addition, and equally important, our group includes implementing partners, governments, ministries of health, and communities, all of whom have played a critical role to date in the trial and have been supportive and engaged partners from the start. So we've just heard the results of 052 once again. There already exists a very strong biological and epidemiological rationale for the use of treatment for prevention. The 052 is the definitive efficacy study. Treatment as prevention works. So what are we waiting for, and why do we need to do a trial? There is as yet no powered effectiveness studies to help us to know if this can work at a population level, and more importantly, how best to deliver this to get the most impact for our money. We don't know whether this intervention can be delivered to scale with adequate uptake to confer a population level effect. There are many uncertainties in the models that we've all seen, such that the population impact of these interventions remains uncertain. There are no trial data on treatment as prevention in terms of effectiveness and cost effectiveness in reducing HIV prevention at a population level. And we have to consider that there are potential adverse effects which need to be explored. These include sexual risk disinhibition, HIV-related stigma, coercion for those people living with HIV who perhaps choose not to take treatment, overburdening of health systems, poor adherence long-term to treatment, potentially ART toxicities, and of course drug resistance at a population level. Policy makers need to know what are the potential challenges, how best to deliver a universal test and treat effectively, safely, whilst avoiding stigma, coercion, and in a cost-effective way. Our hypothesis is that we suggest that delivery of a combination HIV prevention approach that includes universal testing and treatment will confer a significant impact on incidence at a population level. Our primary objective is HIV incidence at the populations we're working in, and we're comparing different combination prevention packages which include universal test and treat. This will be measured amongst members of a randomly selected cohort called the population cohort, and they will be followed up throughout the study period of 36 months. The trial design is as shown here. The pop-art trial is a 3-arm, 2-country cluster randomized trial in Zambia and South Africa. There are 21 large, geographically distinct population clusters, 12 in Zambia and 9 in South Africa, which have been randomized into 3 arms. The average size of the cluster is around 50,000 people, of which half are adults. The total estimated number of people living within these 21 communities is approximately 1.2 million, with an estimated 800,000 individuals living in the intervention arms A and B. HIV prevalence within these communities is estimated to be between 13 and 26%. So our communities have been randomly allocated into one of these 3 arms. The intervention in the 2 arms, A and B, includes a combination package of household-based voluntary testing and counselling, voluntary medical male circumcision for HIV uninfected men, enhanced referral to PMT-CT services for HIV-positive pregnant women, treatment of syndromic STIs, provision of condoms, and antiretroviral therapy for those found to be HIV positive In Arm A, regardless of CD4 count, and in Arm B, according to whatever the current national guidelines are, which are at present less than 350 in both countries. The Arm C communities will receive current standard of care. The inclusion of Arm B at the moment allows separate assessment of the benefit of enhanced house-to-house testing with linkage to care under national guidelines for treatment, and helps us to identify and cost any additional prevention benefit of a universal treatment approach. These data will be important to guide future policy and cost-effectiveness analysis, and of course throughout the trial will be constantly monitored as treatment guidelines change. So what is a cluster? In our trial, a cluster is a community served by a healthcare facility with a predetermined boundary. The clusters have been matched into triplets by HIV prevalence, geographical location, and implementing partner. And there are therefore 4 triplets in Zambia and 3 in South Africa. The communities have agreed to work with us as part of this collaboration, and there are 12 sites, as shown here, in Zambia and 9 in South Africa. Participating communities are, as far as possible, geographically distinct. There are no other major HIV prevention studies planned or ongoing within these communities at present. There is an adequate population size here to minimize the effects of contamination, by which I mean outcome measures that can't be impacted significantly by contact and through sex with people in communities outside of the communities we're working with. And we have worked a lot in the last year and a half to work with our communities who are willing to be involved in our current trial. Specifically, the areas we're working in are around Cape Town and the Western Cape in South Africa, and across the north and southern areas of Zambia, including communities in Lusaka. In fact, our 3 largest communities, with populations exceeding 120,000, are all within suburbs in Lusaka in Zambia. So the secondary objectives of the study are equally important. They will be critical to inform the risks versus the benefits of achieving our primary objective, and will also explore the process measures that were required in order to deliver an impact to population incidence. Sexual behaviour, measured by questionnaires as well as HSV incidents, will be explored, and potential sexual disinhibition will be investigated. There is a large amount of social science research taking place in this trial, which will explore stigma, gender-based violence, and within the study there are nested case control studies which will look into reasons for declining or uptaking different aspects of intervention. Cost-effectiveness and cost-effectiveness modelling will include costs per averted infection through models, as well as individual and societal cost versus benefits. Our mathematical modellers have worked very closely with the study team right from the start and have informed our study design and sample size calculations. The following table highlights the estimated parameter measures required to enable suitable power. It highlights the assumptions we have made upon which we've made our power calculations. And we've assumed overall a greater than 70% annual uptake of the test and treat concept, with about a 10% dropout from care annually. We've assumed that treatment is more than 90% effective at blocking transmission, and we've assumed that we will be able to achieve around about 50% uptake of male circumcision. Taking these assumptions into account, we have anticipated an overall effect of between 58 and 66% reduction in incidence in our Arm A communities over the 3 years, and a 23 to 25 reduction in our Arm B communities. These are quite interesting in the context of the TANZA paper that showed what we've seen in what we're anticipating in Arm B was in a ballpark of what they've already observed. I'd like to just now spend a little bit of time talking a little bit more about the exact components of our intervention package. Earlier on, before lunch, Rob talked in a much more detail about the extension of what is current practice in some populations in Zambia already, and many of these components are actually already in place in some of the communities. Our goal is to coordinate the delivery in a uniform and as simplified way as possible through a team of community healthcare providers, which we've termed the CHIPS teams. And these will work through the communities as teams of men and women in arms A and B. They will work through home-based testing to all consenting households and offer testing on the spot with point-of-care tests to every member within the household who consents to take a test, as well as children and young people. They will return regularly to visit those households to support linkage to refer to male circumcision and to encourage linkage onto treatment. Completely separate from this cohort is the population cohort, which you can see on the right-hand side of this figure. And these are totally part of the research component of the work, and these two pieces of work go in parallel. So the CHIPS teams we consider are part of our intervention package, whereas the research teams are looking at the population cohort as a window, if you like, of what's going on within the communities. The research component of the trial will be separately led by a research team who will prospectively recruit and randomly select individual members from a chosen household to enroll into our population cohort. The cohorts are approximately 2,500 individuals, so that's around about 10% of the adults of those populations, and they will be followed up. These individuals will receive all the study interventions as outlined separately by the CHIPS teams, depending on which arms they're in. They will donate a single blood sample annually, which will be stored for HIV testing and some of our secondary outcome measures, and they will complete a questionnaire. The intervention offered by the research teams to these participants will be absolutely minimal in an attempt to avoid distortion, the Hawthorne effect. But home-based testing for HIV will, of course, be offered at each visit by the research teams. So where are we up to now? We had an amazing randomization ceremony in parallel in both countries in February this year. The randomization was an open ceremony called a restricted randomization, and it occurred in parallel. Numbers corresponding to specific communities and letters A, B, and C were put on footballs and picked out of a bag by members of the community. Restricted randomization is a special way of dividing the 21 communities into 3 groups in 7 matched triplets. We get an enormously large number of possible permutations that would then balance for prevalence of HIV, ART coverage, and population size. This has ended up with a restriction to 4,000 potential allocations of these different communities we're working with. We had a very good balance for HIV prevalence, ART uptake, and population size across those groups. And of these 4,000 acceptable allocations, 1 was chosen at a time through numbers on the footballs. This is a picture of one of our randomization ceremonies in South Africa, where representation of the community were lined up according to the allocation of the randomization. So where are we now? The final protocol has been reviewed and approved by regulatory US and in-country partners. We have ethical approval in South Africa, and we're awaiting review next week from the Zambian South African Committee. The implementing partners have begun to employ and train our CHIPS teams and enhance the healthcare systems in preparation to start the trial. We hope to start in both countries in June this year. We've completed a household census, and we've had a lot of informative community work which has been led by our social science teams to look at community concepts of what our trial is all about, how they would like to be involved, and how they would like us to work with them. We also have ancillary studies which are being contemplated to look at phylogenetics in the future towards the end of this trial, and more work looking at stigma and the impact. So in summary, our timeline of the trial is shown here, with a planned interim analysis importantly in 2015, where the annual research teams who will enroll the population cohorts will be reviewed in terms of viral suppression, HIV incidence across the arms. We will enroll, as you can see here, in the intervention, the CHIPS, starting working their way through the communities from the second half of this year, and in parallel, the population cohort will be enrolled into the research through the separate research teams. I'd really like to now thank you for listening, and thank you for the many, many people who've tirelessly worked together to support this study so far. It's very daunting, but very exciting. And should the world wait for these results, I think as a community of advocates and researchers, we must continue to base our policy decisions on unbiased, rational evidence to inform the best investment in the population effects of treatment as prevention. Thank you.